Persistent Residual Contamination in Endoscope Channels, a Fluorescence Microscopy Study. Introduction. Endoscopic interventions are common worldwide, ranging from simple observations of non-sterile body cavities to tissue sampling and more complex and invasive procedures such as endoscopic retrograde cholangiopancreatography, ERCP. Outbreaks of various antibiotic-resistant bacterial strains have been reported associated with the use of ERCP duodenoscopes, gastroscopes, cystoscopes, or ureteroscopes. Flexible luminal endoscopes are complex, fragile, and expensive instruments. They are used repeatedly with a relatively rapid turnaround and present various reprocessing challenges because of their complexity and their incompatibility with heat sterilization, leading to reliance on material-compatible chemical or alternative treatments. While luminal flexible endoscopes may be refurbished and parts, including the various channels, may be replaced at a significant cost, high throughput within demanding endoscopy units prevents systematic inspection before each use. Current methods for assessing endoscope cleanliness rely on sufficient recovery after swabbing or flushing, with an inherent effect on sensitivity. Bearing in mind these limitations, reported findings from such tests demonstrate that endoscopes remain significantly contaminated even after recommended reprocessing procedures. Flexible endoscopes are cleaned according to the manufacturer's recommendations, and there is a thriving market for specifically designed cleaning chemical methods and automated endoscope reprocessors. The Spaulding classification, which originated in the 1960s and originally considered endoscopes as semi-critical devices, is increasingly challenged by the complexity of modern instruments and endoscopic interventions. The adsorption of patient tissue proteins and potentially embedded bacterial, viral, or prion contamination in endoscope lumens may have significant implications. Proteinaceous deposits provide a favorable background for microbial colonization and biofilm formation, and further increase the risk of inadequate disinfection or sterilization. Chemical and bacterial residues may induce toxic reactions or produce health-threatening infections in immunocompromised patients. There is also an increasing risk of transmission of antimicrobial-resistant strains. Reported iatrogenic infections through instrumentation are often attributed to equipment failure, poor reprocessing protocol, or negligence, though endoscopes involved in several recent outbreaks were reprocessed in accordance with guidelines. The potential extent of subclinical cross-contaminations worldwide remains unknown, as some patients may remain asymptomatic. The issues with bacterial contamination in endoscopes are well known and have been the focus of a number of studies. The identification in the 1980s of the misfolded prion protein, PRPSC, as the most likely infectious agent of transmissible spongiform encephalopathies, TSEs, led to a number of new concerns. Transmissible encephalopathies are invariably fatal neurological diseases. Human TSEs identified so far include Kuru, fatal familial insomnia, Gerstmann-Straussler-Scheinker syndrome, and the sporadic and variant forms of Creutzfeldt-Jakob disease, SCJD and VCJD, respectively. Pathogenic prions, PRPSC, are amyloid protease-resistant proteins capable of aggregating in the central nervous system, leading to fatal neurodegeneration. Worldwide, sporadic CJD has an estimated incidence of approximately 1 per million in the general population. However, recent prevalence studies in the British population based on the analysis of lymphoid tissues suggest that 1 in 2,000 people are asymptomatic carriers of VCJD, possibly following exposure to bovine spongiform encephalopathy, BSE, infected meat during the peak of the BSE crisis in the 1990s. There is a concern that VCJD in the least susceptible individuals may present a similarly lengthy incubation period to that observed in other TSEs, up to 50 years for Kuru. Although these patients may not develop symptoms during their lifetime, the wide tissue distribution of potential infectivity seen in VCJD, including in blood, implies a risk of transmission through surgical procedures. Consequently, in the UK, despite the claims from manufacturers of decontamination products, endoscopes and other reusable instruments that come into contact with potentially infectious tissues from identified VCJD patients or patients deemed at increased risk of incubating the disease are subsequently removed from general use at a significant cost. The particular issues relating to VCJD in the UK have prompted a number of studies on the actual efficacy of reprocessing regimens against proteinaceous contamination to obtain a better understanding of current potential shortcomings, particularly in heat labile endoscopes. In the current study, working channels from various types of decommissioned endoscopes, which had been in service until recently, were extracted to identify and quantify potential residual contamination present in the lumen, particularly biofilms and protein deposits, including amyloid aggregates characteristic of some PRPSC-infected tissues. Using new and used endoscope working channels, the efficacy of extended or duplicated enzymatic treatment was also assessed, since these have been proposed as simple alternatives to tackle the issue of hard-to-remove hydrophobic prions in endoscopes used in known VCJD patients. The findings are discussed globally in terms of potential risks that may be associated with endoscopic procedures. Background and study aims. The increasing demand for endoscopic procedures poses new contamination challenges given developing antimicrobial resistance worldwide and potential viral or prion diseases in populations at risk. We examined working channels from reusable luminal endoscopes used in recent years. Methods. Very sensitive fluorescence epimicroscopy was used to examine working channels from 6 decommissioned and 6 factory new channels as received or following spiking and washing in the laboratory. Results. After a single contamination and wash test cycle, new channels retained approximately 75 picograms per millimeter squared of proteins. Through 7 subsequent cycles, residual proteins fluctuated between 25 and 75 picograms per millimeter squared. Decommissioned channels harbored 1 to 4 micrograms of proteins each, except in one gastroscope, 33 micrograms, including up to 2% amyloid proteins except in one gastroscope and one sigmoidoscope, with over 80%. Lumens showed wearing with established abraded biofilms in 3 cases. After spiking with scrapie-infected blood components and washing, residual protein levels in new channels varied following standard, 17.23 picograms per millimeter squared, duplicated 2.39 picograms per millimeter squared, or extended 11.3 picograms per millimeter squared washing. No changes were measured among the long-established contamination in old channels. Conclusion. The observations of this study suggest that wear effects in endoscope lumens may contribute to the adsorption of proteins, thus facilitating retention and survival of bacteria. As demonstrated by recent outbreaks worldwide despite recommended reprocessing, the development of antimicrobial-resistant bacterial strains, and the estimated prevalence of variant Creutzfeldt-Jakob disease, VCJD, in the UK particularly, combined with increasing demand for endoscopic procedures, call for sustained precautions and improved methods for the reprocessing of non-autoclavable, reusable surgical instruments.